So let me pull the pin
Okay.
and ask the obvious question, but sometimes obvious questions have strange answers. What are the potential consequences to patients of using this stuff raw?
It doesn't work.
Doesn't work. Yeah,
It doesn't
They
work
still
well.
short
They
of
don't
breath.
get it into where it needs to
They
be.
still short of breath because I'm taking my medication short of breath because you're not taking the medication right.
So
it doesn't do what it's supposed to be
But to
doing.
go beyond that, I mean, the clear implication is you're not going to take the medicine right, it's not going to work.
Right.
Well, you end up in the ED, you end up in the hospital,
Right.
you end up with
Exactly.
exacerbations, you end up limiting your activities further and further and potentially having more rapid disease progression because of all those negative consequences.
And it occurs to me that if the patient thinks he or she's doing it right and it's not working, there's depression. And
Or
there's dissatisfaction.
Frustration.
And
anger,
there's
yes.
a certain amount of hopelessness.
Yep.
I
Yes.
think I'm doing it right and it's not
Yes.
working.
Yeah.
I must be
It
one
must
of
be
those people.
hopeless. Yeah.
Well,
Absolutely right.
I'm hopeless or my doctor's an idiot. I mean,
Right.
whichever one it
Close
may be.
call.
It is, but it may both be right. But I mean,
True, unrelated. I mean,
Well, but I've heard that before. I mean, I remember sitting in the Chicago airport watching this woman exhale while she pushes her MDI button
Yeah.
and saying, my doctor doesn't know what they're talking about. This doesn't help at all. And, 3 hours later, because we were delayed, of course.
I was going to say the Chicago airport.
Yeah, I know.
Plenty of time
I
to
did.
observe.
I finally, after the 5th time she took it wrong, I couldn't stand it. I said, excuse me. I showed her how to do it. And about 3 hours later, when we finally got on the plane, she was ahead of me, and she said to her daughter, this stuff really does work. So, I mean,
That's an N of 1.
it is an N of 1, but it is the kind of thing. If we can take the time and figure out how to do it, our patients are really, really going to benefit. And one of the people in our office is we use the phlebotomist or the lab person because in the beginning of the day they're crazy busy. Don't ever start at 8 a.m. But there are times during the day when things are a little slower, and most of them love adding another skill to what they can do. So think outside of the box of who can do this.
Peter, we've talked before about this. I mean, one of the gaps in COPD care is that we have gotten limited classes of medicine. So only one medicine of a new class has actually been approved in the last 10 or 15 years. That doesn't mean our therapies haven't gotten better. The combinations, the new versions of the older medicines clearly work. We have therapies that can help people, but if you don't use them correctly, you have no shot.
But my question then becomes, if the doc is sitting in the office saying, I gave the right drug, I gave the right delivery device, the patient comes back not better, is the doc, in your experience, considering maybe the patient's not using it right? Is that something in the differential?
Unfortunately, it's frequently not. No. The first knee-jerk reaction is we better add something else.
Yeah.
And instead, it should be adherence and inhaler technique and exposure.
Show me how you're using it.
Right, show me how you're using it. Tell me about how you're able to use it. How often? I know this is hard with your 10 medicines. How often do you find you forget? So if you deal with adherence and inhaler technique, and then of course triggers, are you still smoking, or is somebody else smoking in your house? You can make huge strides forward with no added side effects, no added cost to the patient, and it makes a huge difference.
Yeah. Is it fair to say, if you had to pick one takeaway from what we've been discussing now for over an hour, make sure the patient's taking the drug the way you think the patient's taking the drug, and if the drug isn't working, check?
Yeah.
Invest in education.
Yeah, I think that's
Invest in patient education. That could be the best buck.
The other thing that I just want to stress, because we passed on and I don't want to, we talked about the fact that some 25% of people with COPD may never have smoked. They may have some of these other exposures, and there's certainly some genetic issues. But cigarette smoking remains in the United States the primary cause of this disease. And we don't do a great job getting people off cigarettes. Now, part of that is that, and my friends can comment as well, is that the average is 8 to 10 attempts at quitting. And docs don't like to fail, providers don't like to fail. So each time they fail, we tend to get less enthusiastic about pushing forward because we've got a lot of other things we need to do. It is still the only thing that we have found which changes the course of the disease. You know, yes, there's LVRS, yes, there's oxygen, but clearly the data that cigarette smoking cessation affects the course of the disease is clearer than anything else. I just don't want to not stress that issue.
There is some data suggesting that there are some time points at which you're more likely to be successful.
Yes.
The patient is in the hospital with an exacerbation. They're in the emergency room. They're getting their prescription for oral steroids and antibiotics in your office. And by the way, could we add a smoking cessation therapy to this? So it's just like with MIs. When do they stop smoking? Right after their MI. Well, with an exacerbation or an adverse event, this is a good time to try again.
I remember Jim Lehrer on PBS, a news anchor who had an MI, got on the air after he recovered, and he said, I always thought I should exercise. I never thought I had the time. I do. And I just woke up. You know, so it's the same critical moment, teachable moment, huh?
Right.
One other thing I'd like to emphasize in terms of the personalization of medicine, the communication and education is, you know, we always hear we need to be good listeners, and many of us as physicians have always been in the, used to be in the authoritative type of approach, telling people what to do, and then we're not successful. And we really need to be detectives as to why that is. And so we need to be able to better communicate with our patient in their context and have a conversation with them, not as, you know, doctor-patient necessarily, but two people having a conversation as to why our therapy is not successful, in your own words, or perhaps even using intermediaries. Like in the South, we've had trouble at times talking with different groups of people. I've used members of the clergy, for example, to help me understand what is wrong, why things aren't working, and members of the family and what have you. It's all about the patient. That's really the only thing we're here for.
And is it fair to say?
Go from there.
Yeah, and we do have to move on, but it goes without saying, this is an addictive drug. And
right.
Quitting an addiction isn't easy.
It's very hard.
It is hard.
Yeah.
And simply looking at a patient and say, stop smoking.
Stop smoking.
That's
not going to get it. Why isn't it working?
No, but offering again repeated
support.
And you're right,
Absolutely.
you have not failed until the 30th time.
Yeah.
You
finding
tried.
that moment that Barbara mentioned, that when the patient is in a teachable predicament or situation, and exploiting that to their benefit.